sharing our intro slides. Perfect. All right. So thank you all for being here. As you know, this is part of our initiative to advance the science on recovery community centers. And these are the brains behind all of the brains and hearts, I should say, behind the activities that we do. And we always want input from you all about next things. And you've probably seen evolving how different we're doing things compared to what 22 months ago when we had the first seminar. So next slide, please. Just as a reminder, so the three main things that we currently have that we are providing is, of course, our monthly seminar series. You're here right now. There's our pie sort of who's here. Our goal really is to get out of our silos, to talk to stakeholder groups we usually don't talk to in our everyday life, so we can build together towards research on recovery community centers, like what outcome measures can we agree on, what are the issues that are really difficult, challenges that we are encountering, that sort of thing. That's why it's really great for us that you all are here and that we're coming from so many different perspectives. And that's why we love all the things that you share and bring up in this setting. It really builds forward to what we can all do together. We do have pilot study funding, and today you will be treated to our first outcome presentation. The first team is ready to present, and we are very excited about this. We also have more funding, so if you love what you hear today and you have ideas for your own research projects, please do apply. We have the links here. Love to, if you have questions about it, you can take a look at what we have on the website and then get in touch. Happy to do Zoom meetings with you all to chat about it and setting up the research projects that you guys want to do. Also, just a reminder that we have a repository of scales. We come across this question a lot about what are good measures to use for different aspects of it. This is a work in progress. It's grown a lot since we started it. Sometimes we get requests from people and saying, how can you measure X, Y, Z? And then our team spends some time looking for good measures and discussing with other colleagues and then ultimately putting it on our website. So if you have a request for something or you have a great scale that you use all the time and you think everybody else should use it too, that'll be great, because if we use the same scales, we can compare data better. So that's great for everybody involved if we share our research tools. So with these reminders, if you want to go on to the next slide, Catherine. Here are our next two seminars that are coming up. We will have Ms. Danielle O'Brien of the Bureau of Substance Abuse Addiction Services from Massachusetts presenting in March. And then we will have the next pilot project present in April. The links are up. Please take a look and hope to see you there. All right, next up is our polling questions. As always, we're going to be asking you from what perspective you come, what stakeholder group you're in, and then we're going to have some questions towards the end to preview today's topic. So please take a moment to complete the poll that just showed up. You kind of have to use the thing on the side to scroll down, and then when you have completed everything, you can hit the submit button. So I'll do that too now. And thank you, Diadora, for posting all the links to the things I just mentioned, so in case people want to click there. So, Warren, it's possible that you haven't scrolled all the way to the bottom or that you missed a question. If you just want to double check there. Once you've answered all the questions, the submit button should turn blue. Perfect.
We're at 60% so far.
We'll give it up a minute or two since the questions are previewing what we're about to hear. So it's nice that people are taking the time to think about it. For resetting the survey, you mean the poll, the restarting the poll?
Yes.
I don't know
do
if
it?
you can.
I only have an option to end the poll, so I don't think that I can relaunch it now.
All right. How are we doing now, Catherine?
We're at 76%.
All right. I think that's pretty good. Unless anybody wants some more time, in which case I'm happy to wait.
Oh, sorry, I ended it.
All right, very good. Then let's display. All right, so everybody gets their own scroll thing here. So again, you can take the bar at the right to kind of scroll through. So we have here our recovery community centers. 25% of us in the room are RCC staff and leaders. We also have a large number of scientists in the room, 34%. And as always, we have a wide variety of fields. Prescribers, Vinod, thank you for being here and being our inside there. Let's go further down for the poll. Let's look at our questions for today. Have you ever needed to think about the economic impact for running an RCC? And 65% said yes. Okay. A program has to save money to be cost effective. This is a true false statement. Ooh, and 76% of us got it. Wait, did you say it's true? The correct, oh, that was my answer, which was not true. It's actually the correct answer is false, which 76% of us could correct. Excellent. Have you ever been told that peer recovery support services are not cost effective? A quarter of us have. Do you think that peer recovery support services are not cost effective? Yes, the majority thinks that they are. No, that they are cost effective, okay. And bystander Naloxone is a cost effective 91%. Very good. Have you ever had to make the case for funding peer recovery support services? Half. Okay, well, in that case, you're exactly in the right spot. If you have to make this case, we will learn a lot about that. Perfect. Before we get there, next slide, Catherine, we will get to hear from Anita Bradley from the Northern Ohio Recovery Association, and she will give answer to the question of what happens when you walk through the door of a Northern Ohio Recovery Association. Anita, all yours.
There you go. Hi, thanks for having me. So basically, when people come to the organization, they're greeted with a bottle of water, just something to make them feel comfortable. And sometimes they call the phone number before they get there. Sometimes people walk in. If they call the phone number to the organization, then they're given a screen. Basically to find out exactly what's going on, because often, I mean, like last week, a couple people came in that was just dealing with grief. Even though there was some substance use in the background, they said they weren't there for that. However, we talked to them about pairing them up with a peer after they were screened to build the relationship with them. Of course, there's the forms that we have to fill out to make sure we figure out exactly where the payment source is coming from, if at all, or if it's going to be grant related, because we have a variety of different funding mechanisms. And then they sit down with someone from our intake department, and they're given a full-blown psychosocial assessment and paired with a peer, and then through the basically the organizational workflow, we determine where's the best place for them to be. Sometimes it's just they're given a recovery coach to work with them. Sometimes they are in need of residential treatment where they have to come in. We do have the one facility where we can take a woman with children. So we also have a men's facility. So it just depends on their their sex. And so, it's either treatment, we have different levels of care. In Ohio, they call it levels of care, just dependent upon what their background determines. And then typically they're placed into some program or given a individualized treatment plan. I'm a big proponent of not providing a program that we've determined that pre-exists, but to make sure that we're looking at what the person's need is, because everyone is an individual. just learning a lot of different things from, traveling around the country, even as important as making sure that we look at our paperwork language. So I'm going to be talking more with my management team about making sure that the paperwork is friendly to all populations, race, gender, age, sexual preferences, so that people feel welcome. Because that's one of the biggest things when accessing treatment. Sometimes we're inhibited by the things that we've gone through. So at NORA, we really like to make sure that people feel welcome. And if there's someone with a special expertise with their background, then we try to make sure that we link them up with them.
I did say thank you, but I was muted.
Oh.
Thank you, Anita, for giving us this.
I didn't know if there was another question or not, but I'll keep going.
Excellent, thank you. All right.
Oh, wait. And one last thing. And so also what's important is when they leave their discharge is that we follow them into the community, because the organization was birthed on the premise that relapse happened in the community and not in a sheltered environment. And so in the sheltered environment, of course, our data always shows people are doing great. But we want them to do great in the community and to make that transition. And so that's where the peer piece follows them out there. So I forgot about that. That's really, really important. So.
Perfect. Thank you for adding that.
Mm-hmm.
All right. And now, Catherine, if you can go to the next slide for us. Here is the team, the investigators of the pilot project that was funded through the NIDA R24 that also funds the seminar series. And I'll turn it over now to our presentation team, Dr. Shelton Brown, Ms. Castedo de Martell, and Margaret B. And I have to move over Margaret Moore. Thank you. And you have your own slides that we need to set up? Yes.
Yes. Thank you so much. I'm going to get the slides set up here and make sure I am putting it in presenter mode. Okay. Well, thanks so much for having us today. We're going to be telling you about our recently wrapped up pilot study of peer recovery support services and bystander naloxone distribution cost effectiveness, and how we turn that into a calculator. And we're all in the same room. We're all going to be using my mic. I've got Marnie and Shelton here. I did also want to acknowledge another member of our team, Hannah Wang, who was responsible for turning our project into the beautiful web-based calculator that you'll be seeing in a little bit. So just to give you a brief outline of what we're going to talk about today, I'm going to go over some background of the project first. Then we're going to organize the main part just by exactly the same aims that we submitted in our grant proposal. We're going to talk about the underlying analysis of the peer recovery support services, and then how we turned that into one component of the calculator, and we turned a component, an existing study of bystander naloxone distribution, into another component of that calculator. We'll take a very brief look at the calculator, and then we'll talk about some future research directions. We're actually going to leave the kind of hands-on tutorial of the calculator for that half-hour session after. So we'll just take a peek at it today. So diving right into the background, what we're working towards, our ultimate goal, is a multifaceted tool for communities and organizations that would make cost effectiveness information much more accessible and interpretable. So the form that's going to take is a free web-based calculator that's going to be multifaceted in that it can look at multiple substance use interventions simultaneously. It would hopefully empower stakeholders to use cost effectiveness information and to increase support for existing programs, and maybe also move communities towards adopting new programs where they don't already exist. As a bonus, we would be filling in some of the existing gaps in the evidence base around the economic evaluations of peer-driven substance use interventions in particular. There's very little economic evaluation of peer-driven interventions. So that would be a kind of an added goal. There's a lot of work to do. Our approach has been kind of hacking away at this piece by piece. For my master's thesis, I did a cost effectiveness calculator for collegiate recovery programs. It's very basic. It's just in Excel. You can check that out later. This funding that we got from the Recovery Research Institute represents our first step towards building out that web-based calculator that we are envisioning. And for this project, we tackled two components. We did the full underlying cost effectiveness analysis of peer recovery support services, and then made that into calculator component. Just if you're not aware of what peer recovery support services are, I know many of you are, but that involves taking somebody with lived experience of substance use disorder recovery, a peer, who's then trained and credentialed to provide support to somebody who's going through the same thing or struggling with substance use in some way. We're looking at specifically the long-term form that is kind of lower intensity. A lot of recovery community centers are providing that kind of service. And then we also took an existing cost effectiveness analysis of bystander naloxone distribution, Coffin and Sullivan 2013, updated all of those parameters, and then made that into another calculator component. Bystander naloxone distribution, I know some of you answered, you didn't know what that was. That just involves a recovery community center or some other organization giving out doses of naloxone and some basic training on how to use it to members of the public, people who might encounter somebody experiencing an overdose, a librarian, somebody who works in a recovery residence, somebody who just has friends and relatives that use opioids. So really just anybody in the community. We'll also briefly touch on some of the future planned work that we want to do, including testing some potential impacts of the calculator. So before we dive into our project, I'm going to give you a super short orientation to cost effectiveness analysis. There is a much longer tutorial available on the calculator site already. You'll see this URL again later, so don't worry. This is going to be really brief, but if you do want to dig into this more, check out that longer tutorial. So whenever we have an intervention or a program or an activity, we have resources that go into that intervention to make it happen. And then we have good stuff or benefits that come out of that intervention or program. And cost effectiveness analysis and other methods of economic evaluation just tell us about the balance between resources going in and good stuff coming out. The result that we're looking for in a cost effectiveness analysis is the incremental cost effectiveness ratio, or ICER, that's up here in the corner. We find that result by finding the difference in costs of the intervention, the new thing that we're testing, PRSS or bystander naloxone distribution, and the cost of treatment as usual, some standard of care, what people are tending to do right now. So we find that difference in cost, we divide it by the difference in effects, and that gives us that cost effectiveness ratio. Now, it's important to note that we are dealing with dollar signs. We're assigning a dollar value to everything on the top of this equation. And we are not assigning a dollar value to anything on the bottom. And that's important because there's some other methods of economic evaluation where we do assign a dollar value to those benefits, to those effects. And that can be a little bit tricky. And that's especially tricky when we're talking about something like recovery, where there's evolving definitions of what recovery means. We're still really working out the best ways to kind of measure how good recovery is. So that's an important caveat there. I like this method because we don't have to assign a dollar value to that. For costs, we want to look at it at least two different ways. From the societal perspective and the health system perspective. Societal includes stuff like patient time and criminal justice involvement, while health system doesn't. It's really just more contained. And then on the effects side, we always want to look at this term here, QALYs, quality adjusted life years. And that's because other studies of cost effectiveness also use quality adjusted life years, or QALYs. So that lets us compare to other types of interventions or programs, both in the substance use realm and way outside of it too. So it lets us compare across a ton of different interventions when we always use that one standard way of looking at effects. We also want to look at effects in a way that's meaningful to the people who are actually going to be using this information. So for example, we might want to look at effects in terms of the number of people in recovery, right? So we're going to have at least 2 results. We might even have 4 or more results.
And yeah, there was a question about the denominator. Can you talk a bit about what the standard unit of measure is in the denominator?
Yeah, so it just depends. We can convert something to quality adjusted life years. So we would measure that by, we'd have to have some way of converting the utility of that health state. We have to kind of define the health state. So we would then convert that to quality adjusted life years, or if we're looking at something else meaningful, then we would look at it in terms of people in recovery or some other unit that's meaningful. A great example from the tobacco literature is cost per quit, right? So they're looking at difference in quit numbers from different types of tobacco quitting interventions. Okay, all right.
Thank you.
Absolutely. And so what we want to then compare that result, that ICER, to different willingness to pay thresholds. These are kind of the standard willingness to pay thresholds. They're standard because back in the 70s, the US government started paying for dialysis. And this is what a year of dialysis cost back in the 70s. With inflation, it has started to cost more and more, of course. So that's what these other standard thresholds are kind of accounting for. So we want to look at that kind of standard willingness to pay threshold. We know the government's going to pay that. We also want to set a threshold that may be more meaningful to our audience. So a great example is the cost of another treatment episode if you're talking about substance use disorder. That's one of the ones we used for PRSS. So if anything, if your ICER falls below any of these numbers, it's cost effective to that threshold. If it's $49,000, it's cost effective to the $50,000 threshold, and also these ones that are above that. If it is a negative number, if it's below zero, and it's below zero because the top is negative, so the costs are less, but the bottom is positive, so the effects are better, then it's both cost saving and cost effective. And I specify that because you could have a scenario where something costs more, but is less good. And that would also give you a negative number, but that's not good. All right. So I know that was very quick. Again, longer tutorial available already up on the website. And it's got slides that you can download with the full script in there. So you can check that out. We're going to move right along though into the specific aims. So I am going to walk you through the preliminary cost effectiveness analysis of peer recovery support services that we did in the recovery community setting. So remember, let's go back to our basic formula here. We're looking for this incremental cost effectiveness ratio, and we find that by comparing to treatment as usual. What's treatment as usual in the substance use realm? In any given year, the vast majority of people get absolutely nothing, right? Not a doctor's visit, maybe a visit to the ER, but usually something inadequate or nothing at all, right? That's the real scenario. But if we compared peer recovery support services to what people actually get, which is usually nothing, then it would look kind of unfairly positive. Pretty much doing anything is going to be better than doing nothing, right? So we kind of have to set a fairer starting point, a fairer comparison point. So for our model, we wanted to kind of take the most conservative approach initially. So we set the starting point as kind of the ideal standard of care rather than the actual true standard, right? What people actually get. So we started our model with everybody receiving specialty substance use disorder treatment. And here we're modeling, kind of a combination of inpatient and outpatient treatment, but specialty care. So everybody starts with specialty care, and then they either get an additional year of long-term, low-intensity peer recovery support services in a recovery community center, or they're just relying on the effects of treatment alone. After that year, some percent will be in recovery, some percent will have returned to chaotic substance use, and some percent will have died for a variety of reasons. Those percentages, those are going to differ between these two groups. And those differences give us our differences in costs and our differences in effects. And for PRSS, we looked at it two different ways. QALYs, remember we always have to do QALYs, quality adjusted life years. And then I also looked at number of people in recovery at 3 years. And we chose 3 years because that is when it's, for one, to look at kind of the lasting impacts of peer recovery support services. And also because that's when that risk of returning to use to chaotic use would kind of stabilize. Okay. Now we're moving into the results. So Unsurprisingly, I think most of you voted this way on that poll. Unsurprisingly, peer recovery support services is indeed cost effective, no matter which way we looked at it. Here are the specific ICERs, the specific results. But what you really need to take away here is that it was cost effective to all of those willingness to pay thresholds, and it was cost effective from the health system, societal perspective, and no matter which way we looked at effects, QALYs or people in recovery. And then we also did some sensitivity analyses. So we simulated those impacts over 10,000 iterations and found that it was going to be cost effective to our lowest threshold. So this is the cost of another treatment episode, about 60 to 70% of the time. And then it was cost effective to the first of our standard thresholds just about all of the time. I also did one-way sensitivity analyses, and one of the takeaways from that that's really key is that we can best impact cost effectiveness by program improvement, by making sure our programs are as effective as possible, and not through depressing peer worker wages, peer worker pay, or through limiting service utilization. So not by limiting how much of the service people are using. Peer worker pay and that service utilization didn't really have that much of an impact on the model. But if the program was less effective or didn't retain people as well, then that impacted the model more. So we're going to move right along to the first of our second aim and talk about converting that into a calculator.
Okay.
Quick questions here, and Shelton,
Yeah.
actually. Brandon asked if you can tell us very briefly about how you operational defined recovery, since that's something we talk a lot about in this series.
Thank you. That's a great question. It was in my notes and I forgot to say it out loud. It's operationalized as either abstinence or sustained reduced use.
Perfect.
So
Thank you.
basically exclusive of chaotic substance use, right?
Perfect.
Thank you.
Yeah.
Okay, so basically this is just a timeline. It actually goes back a little further than this. We could probably go back about 3 years to, sort of thinking about this. But basically we got the pilot funded. We did some background research in terms of naloxone distribution. There was a pretty good study that was already available. So we kind of used some of the parameters from that. Our model is a little different. And then for PRSS, we basically, created our own model. So then what we did is we had a couple of RCCs, Community for Recovery and Recovery ATX, come and look at our pilot calculator. This is something that's totally new to me. I generally have just made cost effectiveness models in the dark and not played with others. So it was kind of interesting to see people interact with work that I've been a part of. And so then we basically created the model. We made I'm going to show you, I guess, sort of what it looks like behind the screen, and then not the pretty HTML online product that, well, I think it's pretty, that we'll show you later. And we had so when we got feedback from the RCCs, we also got feedback from the National Association of Peer Supporters, or NAPS, in October. And we continue to, if we get feedback here, we can tweak things as well. And we basically just want to expand this. We've got kind of like 2 things that RCCs can do, but there's clearly more things that people do. We want to come up with calculators for those in the future as well. Okay, so this is kind of not the sausage, but this is sort of what it looks like. So we've got for each age category that you pick that you can start. And so in this case, it would be 25 to 30. We basically have a transition matrix. So you've got people that there's a mortality rate with or without SUD use. Okay, then we've also got sort of, if you are, in this case, people are, well, in the PRSS case, people are coming out. And so there's a relapse rate that declines over 3 years. Okay, so if you make it 3 years, you're less likely to relapse. Basically, it's kind of like, I would say, like I say in my class, I would say that the best way to understand it is a little bit like musical chairs. Okay, so if you think about kids and there's 10 rounds and you think about them not sitting down as death, you accrue the life years for everybody in the game. And so, you know, first round, the mortality rate is 1 out of 10 will die. And then the next it's 1 out of 9 and so forth all the way down. You add up the life years. Okay. Then what you would do is you'd say, all right, we're going to have an intervention. Let's add another chair the first round. So there's a cost of that. Well, then of course, everybody lives the first round. So you're adding life years and you're seeing if that's worth it. So that's kind of like, you know, a simple example of what this does. The other thing that you see here, we've got discounting, we've got quality adjustments that we make, you know, for whether you're in chaotic use or not. And, you know, you just are, so you're kind of affecting here's what this person's life is going to be like without any intervention. And here's what it's like with the intervention. So we could talk for 3 hours about this, this slide, but
yeah, this could be its own class. So we'll move along. Thank you. And now we're going to turn it over to Marnie to walk us through the bystander naloxone component.
Okay, so
Thank you.
okay, so here is the equation for the bystander naloxone distribution model. Finding the ICER here. With bystander naloxone, we're focused more on the denominator rather than the numerator because it's more about lives saved rather than the difference in money. So this model works similarly to the PRSS model, but we're not simulating people getting into and staying in recovery. The focus here is just on surviving an overdose. As you can see in the effects in this model on the right side and highlighted in yellow, we look both at QALYs and at the number of people who survive an overdose. So as was mentioned, our calculator for the bystander naloxone is based on a 2013 cost effectiveness study by Kaufman and Sullivan. They looked at distributing naloxone to heroin users for use by bystanders to an overdose from those users. In that study, the authors found that for every 227 naloxone kits that were distributed, 1 life would be saved. This cost effectiveness study was rigorous, and we simplified some of the analysis in constructing this calculator, and we updated several of the parameters that were used in that study. So where relevant, we updated the values to 2019 dollar amounts. We picked 2019 to avoid getting into the pandemic and supply chain issues with dollar values. And then in addition to the updated values, we also review the literature for updated probability values for several of the parameters. So for example, given how extraordinarily effective naloxone is, the rate of EMS transport has dropped significantly since 2013. And that is people who have an overdose somewhere and then are revived with naloxone by a bystander or even by the EMS. They refuse transport to the emergency room because they know naloxone is effective and they don't need to go to the ER. Other parameters we updated included likelihood that an overdose was witnessed, likelihood that if the overdose is witnessed and naloxone is present, someone would administer naloxone, the proportion of overdoses that were witnessed where EMS was called, and then updating medical costs. Our calculation also differs from that done in the Kaufman and Sullivan study for overdoses. We modeled the likelihood of overdose over a 3-year period rather than the likelihood of future overdoses. A couple parameters that we did not include that were in Kaufman and Sullivan are utility and transition from heroin use to discontinued use. There's also a question about survival rate if an overdose is untreated. There are lots and lots of studies that all cite the same probability of surviving of an overdose that if it's not treated. And they cite that as 90% survive, only a 10% fatality rate. And this probability seems to be extremely low. And from what we could find, seems to be based on an old study that looked at overdose surviving from prescribed prescription painkillers, which is obviously different from non-prescription use, street use, and it doesn't consider the potency of fentanyl. We reviewed the literature for updated values on the likelihood of surviving an overdose without any treatment, but couldn't find any. So instead, with our Markov chain, which was what you just saw with Dr. Brown, we built in mortality rates from overdoses that were in excess of background mortality. So when you look at the calculator, you'll see that the inputs for the naloxone distribution, bystander naloxone distribution, are pretty simple, but the underlying model is robust. The calculator allows RCCs to calculate the cost effectiveness of distributing naloxone to their participants in order for witnesses who have access to that naloxone to administer it and hopefully reverse the overdose and save a life.
Okay, thank you, Marnie. Oops, and now we are going to take a quick peek at the calculator. So let's make it full screen here. This is just a really high level overview. The PRSS calculator appears on the first tab. The naloxone calculator appears on the second tab. And then here is a tab that has additional tutorials and resources. The webinar link is what you're looking for if you want kind of a more in-depth dive into cost effectiveness analysis and use of the calculator. We also welcome your feedback. There's a link for feedback here. And then of course you can email any of us. And for both PRSS and naloxone, you have the ability to input your own values here, or you can enter default values. So this is what we used in the base case analysis. And then you just hit submit. For PRSS, you get two kinds of results: societal perspective results and health system perspective results. The top has some interesting stuff that you might want to include in a grant proposal or, in a report out to people. But then down here is where we get into those cost effectiveness results, the ICERs. And it tells you in plain language, yes or no, if it is hitting those different thresholds, and it also gives you the actual ICER. Over here is something pretty fun. So remember that if we use quality adjusted life years, we can compare to other studies that also use quality adjusted life years. So we've included some common medical procedures. Well, I guess not common, but recognizable medical procedures that people generally agree are good and worth doing, right? And then this little triangle shows you where your ICER falls in comparison with these other medical procedures. And naloxone, as Marnie mentioned, the inputs are much simpler. You can input your own or hit default values and hit submit. And then it kind of gives you the same rundown, but it is not looking at those two perspectives. It's health system only. Yeah, health system only. And it's also giving you that same kind of comparison, although for bystander naloxone distribution, it's pretty much always going to be right around zero. It's very cost effective. All right. So let me get out of here and go back into the PowerPoint, because I've got just a couple more things to share with you. We're just going to talk briefly about future directions. We know that recovery utility, so how good recovery is, and again, recovery operationalized as abstinence or sustained reduced use. We don't have a great method for converting that into quality adjusted life years yet. We have a really great opportunity, thanks to Recovery Research Institute, to use data from the National Recovery Survey that measured quality of life among a nationally representative sample of people in recovery, using this measure, the EuroHIS-Qual. It's a measure of quality of life that's a really great measure and works really well, but it's not readily convertible into an estimate of quality adjusted life years. A quality weight is the term for that. So as a next step, we would like to first create just a general measure of recovery utility, get a better handle on that quality of life adjustment. We have a good compromise that we're using for now, but it's a compromise. It's not exact, right? And we'd love to tighten that up. And then we'd love to be able to look at more nuance, recovery utility at different lengths of recovery time. It's probably a little bit worse in the beginning, right? Recovery is uncomfortable for most people. It certainly was for me, right? And then it would probably change over time. It may also change with different age groups or other characteristics. Eventually, we'd love to be able to expand to other ways of measuring quality of life, not just this one measure, maybe things like recovery capital. We could also find a way to convert to quality weights. So that's further down the line. For the calculators themselves, we would really love to test if these can be used as decision aids or if they have impact on dissemination and implementation outcomes, things like adoption of programs in new areas, things like maintenance of existing programs. So we would continue to plug the gaps in the economic evaluation literature, continue to do more of the underlying analyses, create more calculator components, and then to test decision-making and adoption. And it's a big project. We've got a lot of people committed to helping out. So that brings us to the end of our presentation. I apologize. I know we went a little bit over time, but yeah, please feel free to check out the calculator, send us any feedback, and I'm going to stop sharing so we can turn it back over.
Awesome. Thank you so much. And don't worry about the time. We do have the extra time. And I know we also took one in the beginning. So that was fantastic. Thank you, Marnie, Shelton, and Sierra. That was great. Quick poll before we go on to some external discussions that we brought before opening it up to everybody. Catherine, you ready with that post poll, as it were?
Yep, I just launched it.
All right. This time only the 2 questions that you've already seen to just kind of see where you're at this time. How are we doing, Catherine?
We're at 60%.
Our threshold for seeing if you're moving on the note.
I mean, what's the threshold for cost effective?
Oh, for reading that question, you mean? Your personal one, you had several options. You get to choose which one of those you want to have. All right, Catherine, how are we doing?
We're at 77%.
All right, then we can close that out. Here we go. Looks like we are very much thinking that the work shows clearly that RCCs are indeed, and Naloxone bystander are indeed cost effective. We invited Patty McCarthy and Phil Rutherford here to kind of like do external discussing in the sense of they've seen this from their perspectives. How do they digest what they have just heard? I know there was a lot, including a Markov chain Excel spreadsheet that we all were treated to, and the take home messages, and how does it all fit in? And then we want all of you guys to chime in and say, what are your reactions? What are your thoughts? What do you think needs to be considered? So Patty and Phil, lead us away, and then everybody else, please jump in.
Sure. Hi, everyone. Thank you very much, Bettina. And thanks, Sierra, Dr. Brown, and Marnie for your incredibly important tool, and the Recovery Research Institute for funding or selecting this project. I just wanted to quickly mention and thank the 2 of the members of ARCO, the Association of Recovery Community Organizations, that are in Austin, Texas, that participated and piloted this Communities for Recovery and Recovery ATX. So they're part of our national network. And thanks, Anita, for talking about what you do in Ohio. That's fantastic. So at Faces and Voices, we are specifically interested in peer services delivered by RCOs across the nation, and because the RCOs got to know what their communities do best, and they know what's going on the ground. So when I tested this tool myself, the calculator, I found it super easy to use. And it collects data on like the number of people participating, their length of recovery, and it's important that the organization that's using the calculator use their own definition of recovery. So that's self-defined, and that's important. The number of peer support engagements they have, and like the length of time they're engaged with people in single interactions. And then it also collects information on the hourly pay. So all of this information is going to be super important and useful for us on a national level with an advocacy organization to help inform our advocacy work. So most of the RCOs we know are also providing overdose prevention training, and they are distributing Naloxone. So this is going to be helpful for them. We know that the dollar value of a year of life in recovery is just immeasurable. There's so many benefits. We conducted our own a survey 10 years ago called the Life in Recovery Survey with Dr. Alexandra Laudet in 2013. And the survey showed that recovery from alcohol and drug problems demonstrates dramatic improvements in all areas of life. And it really compared active addiction with recovery experiences. So just for example, and that's how this tool, we can integrate and use this information just like we did with this previous survey, but we found that 50% more people pay taxes in recovery than when they're in active addiction. Participation in family activities increases by 50%. Volunteering in the community increases threefold. Steady employment increases by 50%, and twice as many people are furthering their education or training. And so all of this information that we gathered is like the societal benefits of recovery. And so this calculator, in addition to the other information that we have, is just more tools in our toolbox for RCOs who are talking on the state and local level to get with their funders, their policymakers. So we'll be using this information from the calculator and the findings in the research to influence public policy on the local, state, and national level. And our role is to bring this information, new information as it comes out, to Congress when we meet with their staffers, and we work with the federal agencies like SAMHSA and ONDC, Office of National Drug Control Policy, and others. So the more information we have, and the more effective our advocacy will be, and information like this will help convince, Congress and policymakers that, more funding is needed to help sustain this and grow the work that the recovery community centers are doing. And so before I turn it over to Phil, I just want to let you know that we are back on Capitol Hill this year on June 7th for our Hill Day, where hundreds of recovery advocates will be, many of them representing the RCCs. The RCOs will be meeting with Congress. So we encourage everyone to join us, and you can find out more on our website. But super excited about this. It'll be very helpful for the work that we do. Thank you. I'll turn it over to Phil.
Perfect. Thanks, Patty. Yeah, and Patty basically said it all. I think about this kind of more from a layman's perspective, and having been inside and run an RCO and run a recovery community organization. And in my role, I get to talk to a lot of other folks that run RCOs. This information jibes clearly with what's going on. And I think in some ways, the provision of peer recovery support services, it's almost the cost of it is almost an enemy of the service. And what I mean by that is some of the things that are happening in communities are being done so cost effectively as to not even explain why they are needed, right? So I'm thinking specifically about a case in the RCO that I ran, where we were working with people in probation, and what we saw that was over a period of time, people needed less supervision. There was an actual dollar and cent relationship between the amount of supervision that they needed and the length of time engaged with peer recovery support services. And it was a kind of a straight line comparison. And I think this sort of thing goes on all over the country, where the insertion of peer recovery support services actually reduces kind of the total cost of ownership of substance use disorder. So nothing in what was said here was surprising to me as a layman, that it is cost effective to run these services. I think the challenge for us as advocates is to make sure that tools like this get in front of policymakers and other folks, so that they can see that we're talking about peer recovery support services are a great investment as far as things go. I'm thinking of a conversation I had with Bettina over email, where we have these things. We have a data product called a Recovery Data Platform, and we track social determinants of health and measures of distress and like other indicators of people's well-being at RCOs all over the country. And we have these things called the DUH charts, and we call them the DUH charts because those of us involved in the services know that when people spend time engaged with peer recovery support, there is a greater likelihood that they're going to do better. And my conversation with Bettina was like, I said all this stuff and I'm like, yep, in other news, water is wet. And Bettina's response was classic. She said, well, yeah, but we got to prove water is wet. That's how we get funded. And that's, I think that's kind of this, when I think about the calculator, it's a great example of how we know this stuff works, but here's the actual data. Here's the evidence that says these services work and we need to implement them and certainly insert them along the continuum of care. So that's my short take on this. And again, thanks to RRI and NIDA and everybody else, Sierra, that put this together. That's it.
Awesome. Thank you guys for chiming in. What are some thoughts that you all have in seeing this for the first time, or maybe you've played before? Noel, go right ahead. I know you're mid-stretched. I'm already saying you're ready.
Yeah, you almost got me too fast. I couldn't hit the the unmute. So I just want to say, first of all, great job, Sierra. I think this is really, really interesting. I have two questions. The first is, or two, I guess, things that I will say. The first is, I think one thing to think about with this, and my guess is that you've already thought about this and you're already thinking of ways to incorporate this. But it seems to me like somehow having zip codes or some way of tracking like regions or areas would be very, very important for this, because the cost of living here in the Bay Area is going to be completely different than the cost of living in other places. And that will, I think, have an effect on kind of some of these quality of life things. May not be, I just, that would be one thing that I would, because I could run this quality of life thing here, present it to lawmakers here, but they would potentially say, well, this tells us this gives us an overview of what these can say, but what does it mean for here in the Bay Area? And so some way of like having that incorporated into these Markov chains, and I don't know enough about them statistically to understand if that's an option or if other studies or other places do that. But it seems to me that would be something that would be important for all of this. The other thing I would say, and this is just kind of a note that I'm seeing when I look at the actual, so when I look at the Naloxone website, right? Or when I look at your website, your calculator website, and I go to the one, not the one on PRSS, but the one on Naloxone, the question says, what percentage of participants would you like to serve? And so I have no idea how to answer that because it just is not very intuitive. So my suggestion would be to give a little bit better example of what exactly you're talking about, because I'm thinking, in terms of like a collegiate recovery program, we want to serve every student at the school here. So is that the what you're looking for? Is it just students in recovery? Is it, so it's very vague as far as I have no idea how to answer that for what what I'm trying to get at. I want to send this on to our the people that do the Narcan trainings here at the school, but I think that they would need a little bit more understanding of what that means. So those are the only two things I have. Again, really great job, and great use of this grant to really do something cool.
Just
Awesome.
in response, sorry, let me mute. There we go. Okay, in response to the question on percentage served, thank you for that. We can work on rewording it. The idea is that there is an assumed background amount of naloxone that 20% of people who use have naloxone or who have loved ones who have naloxone. So there's a background rate that 20% have it. And then if your center served 1,000 people, would you be looking to give out enough naloxone so that every person who used it got a naloxone kit? That's the idea behind it, but I totally hear what you're saying and we will work on rewording it.
Yeah, and so I guess in our situation, like we're at a school that has, 5,000 students. We want to save all of them potentially. We don't know how many are potentially using, and it really doesn't matter. We want this. We want this in everybody's hands, so that they can save their friend's life if something happens. So I don't know if that can be worked into the calculator, but it would be something I know for other schools that would be really, really important that are having a hard time justifying bringing a service like this onto their campus.
I was just gonna add that I think that sort of what we were thinking is that, you know, people might have, I don't know, $5,000, okay, and they are thinking of things to spend the money on. That might be like a some sort of, I know that doesn't happen very often, but we wish it happened more. But if you just find yourself with a little bit of extra money, would it be cost effective to buy naloxone? So you just sort of figure out how many people you've got in your organization, how much can I afford? Will it be cost effective? So that's kind of what we were thinking. I mean, for sure, you know, we'd like to do everybody, and I think this shows that it would be cost effective. But you know, I think in the real world, you know, we don't have that much money. And I guess that was the first question.
Yeah, maybe we can add an example of that kind of thought process on the
Yeah.
website. Yeah.
But yeah,
Thank you.
Great thoughts. And I love that they're thinking about the input values that go into the calculator. Others of you, have you guys looked at the calculator to kind of see what the input values are? And I think it would be great if there's feedback about how easy is it for you to know this answer, and what ways could it be made easier for you to have those answers, you know, the input values. I think that'd be really helpful for the team to know. But this is exactly the kind of feedback I think it's helpful.
Yeah, and definitely I encourage everybody to use that the survey link that's on the tutorial and resources page. We would love to have your feedback. There's an option to add your email address if you want an answer back, or you want to like have a conversation. You don't have to provide your email address if you don't want to. But yeah, we would love to hear from you.
But who wouldn't want to talk with you guys here? So definitely do your email. No, kidding. Whatever you are comfortable with. Other questions? We have 2 more minutes before we're going to close the recording. And we will stay around. So if somebody wants to actually, you know, take an example and say, let's do this live for our RCC, let's plug in some values, we can do that in the next half hour that we will have. For now, I want to thank you all for being here. So this is the first team, the funded team that presented, and thank you guys for doing an amazing, inspiring job with this. I love the input that you got. You know, Shelton, you mentioned that you typically don't go and talk to people whose calculator you're calculating, and I love that this happened in this case, that you're really interacting and getting to know each other. So that was awesome. Part of our reason to present in the seminar series these results is not just to give you all the results of our funded research, but for this community to help inform the next steps and to comment back and to provide feedback. So I really appreciate you all jumping in and thinking through, and please keep those thinking caps on for the next presentations, for the next teams. This is a great value in moving forward. So thank you all for being here and for sharing your thoughts, and please do reach out over Zoom, email, RedCap links, and so forth to keep the conversation going.